As you know, our graduating residents each are required to give them around. Their LC is PGY-III, finishing up, and he's chosen the topic LGBTQ+. This is to help us understand the needs of youth who fit into these groups. And Daryl. I still need to drink some more coffee.
As Dr. Bukini said, I'm Damian Lafitte. I am a PGY-III. I chose to do LGBTQ plus medicine and where you fit in. My advisor was Dr. Love, who helped me kind of coordinate everything. Disclaimer, I have nothing to disclose. My objectives for this talk are to define commonly used terms and identify how they impact LGBTQ plus youth. I will go ahead and say I will not be saying LGBTQ plus the whole time because it's a tongue tie. Discuss and outline topics that LGBTQ plus youth are at greater risk for experiencing, and recognize and improve communication between healthcare providers and LGBTQ plus families. The reason that I chose this topic is because I feel like I can offer a unique perspective on it. I am gay, and that is still one of the hardest things for me to say as a 30-year-old. I came out whenever I was 22 years old, and it's still hard for me to say that out loud. I am the youngest of 3 kids. I grew up with a mom and a dad who were both very Southern and had very specific ideas of who they wanted me to be. And let's just say I broke every rule that they had for me. Growing up, I always knew that I was different. I always knew that I wasn't like all of the other boys. I didn't know what that difference was. I just knew I wasn't quite like them. As I got older, I recognized what that difference was, and that was a scary realization, because I grew up in a home where if my parents saw a movie or a TV show where there was a gay couple, they were gross and they were disgusting. If they saw a man that was acting more feminine, he was nasty. If there was a female that was more masculine, she was going to hell. And one of the big things that always stuck out to me is hearing my parents say if that was my child, they would no longer be my child. And so I was, sorry, I'm shaking. I was very depressed for a long time. To my mom's credit, she did notice that, there was something not quite right, that I wasn't as happy as I usually was. And so she took me to see my primary care physician. This is a man who, whenever I walked into his office, one of the first things he said to me is, "How the girl's treating you? How's your girlfriend?" The moment that that was said to me is the moment that I would just completely shut down, because those are the same things that my parents would say to me, and I knew how they viewed me. So how was I supposed to open up to someone and tell them what was wrong with me whenever I thought that they would view me the same way that I knew my parents did? And so I stayed in that very dark place for a very long time, because I wasn't able to get the health care that I needed because I didn't have someone that I could turn to. It wasn't until I was about 22 when I decided that I wasn't going to keep putting other people's happiness above mine. And so I chose to come out and live authentically. And I think that that's what gives me the perspective to kind of give this talk and hopefully give you guys some perspective as well. I am by no means a representative of the entire community, but let's go. So what does it all mean? There's so many terms, and me, myself, I get confused by some of them. There's new ones added. Sometimes I have no idea what it means. But I'm not afraid to look it up. Gay and lesbian, kind of the standard one, attracted to the same gender. Bisexual, attracted to both genders. Pansexual, attracted to all genders. Queer, meaning you are attracted to something that isn't part of those dominant norms that I just previously listed. Asexual, no sexual attraction. Cisgender, you identify with the sex that you were identified at birth. Transgender, you identify with the gender that is outside of the sex that you were assigned at birth. Bigender, you identify with both genders. Genderqueer, you are somewhere outside of that binary of man and female. And gender fluid, you feel as if you are man sometimes, a female sometimes, other sometimes. It is all very fluid. Why does this matter? I kind of looked up and Googled, how do I make this more understandable? And the first thing that popped up was this gender unicorn. It was actually put together by Trans Student Educational Resources. There was a genderbread man before, but it didn't have things like asexual and stuff, so they want to be all inclusive as they could be. The way that it's filled out is off to this side, is you don't identify, and as the arrow goes that way, you more strongly identify. Gender identity is how you identify, exactly what it sounds like. Gender expression is your outward expression, the clothes that you choose to wear, your hair, your makeup, your sex assigned at birth or your chromosomes and the hormones. Physical and emotional attraction are exactly what they sound like, what you're physically and emotionally attracted to. If I was to fill this out, fun, I would, here I don't identify as a female, I identify as a male, not other. My gender expression would probably be a little bit more feminine than some of the guys in the room, masculine. Over here, other here, assigned male. Physically attracted to, there. Men over here, other here. Emotional attraction, I would say females up there and men obviously here. There is a difference between physical and emotional attraction. I think my emotional attraction to females is where I get my best friends from. So the reason that this matters is, this is a quote from the GLAAD Accelerating Acceptance 2017. Young people today are more accepting of LGBTQ people than ever before, and as acceptance has grown in this country, so too has the number of young people who describe themselves as LGBTQ. So these titles and these labels and not labels are going to continue to grow. What this GLAAD Accelerating Acceptance did is they polled about 2,000 individuals and kind of gauged how accepting they were pretty much. The first statistics that they have up is how many of that group identified as LGBTQ. The total population was 12%, with the majority being in that 18 to 34 age group at 20%, 35 to 51, 12%, 52 at 7%, and greater than 72 at 5%. What this means for us as pediatricians is that younger age group is where we're going to see all of these individuals that are identifying outside of maybe social norms. Another important terms from that survey were allies, detached supporters, and resistors. Allies are non-LGBT respondents who are somewhat or comfortable or very comfortable in all situations. A detached supporter is a non-LGBT respondent whose comfortable level kind of varies. They're not necessarily opposed, and they don't necessarily support. Resistors, very or somewhat uncomfortable. To kind of put it in perspective, I would call my parents detached supporters. I know they love me, but their love almost kind of comes with a condition. I was just now allowed to start going to family events about 2 or so years ago. Whenever I go, I'm not allowed to show any type of affection towards my partner of almost 5 years. I'm not allowed to be too gay, and my nieces and nephews are not allowed to know anything about that part of me. So while they don't necessarily oppose, they don't necessarily support either. And this is kind of the breakdown of allies, detached supporters, and resistors based off the age ranges. I'm not going to go through all of it, but a pretty reassuring part is age groups 18 to 34, 35 to 51, and 52 to 51, all 50%, the stats are 51% consider themselves allies, which is pretty good. And this was pretty interesting to me. So they polled them and asked how uncomfortable they would be in certain situations. It's broken down from 2014, 15, and 16. 2017 is actually coming out soon. And they asked them, having an LGBTQ member in your place of worship, how uncomfortable, how many of you would be uncomfortable? 22% said that they would be uncomfortable. Seeing a coworker's wedding picture, 25%. A family member, 27%. knowing that your child's teacher and knowing that your doctor is 28%, seeing a same-sex couple hold hands, 29%, and knowing that your child has had a history lesson on LGBTQ culture, 34%. Take into mind that this was not differentiated out by region, culture, or anything like that. Here in the South, we know that we're sometimes a little behind on some things. I myself have never held my partner's hand in public because I'm honestly scared to do that. And honestly, because there's this internalized shame that I've been taught to have. And kind of using that to transition into the next portion of the talk, I just have a short little video. I remember watching this a couple of years ago, made an impact on me. And so moving on to the next portion of the talk, how does this all fit into medicine, especially with pediatrics? So the thing that we have to remember is being LGBTQ is not the problem. The problem is the weakened support system and the increased pressures that these kids face, whether it be bullying, whether it be family conflict and rejection, minority stress, childhood abuse, gender stereotypes, and peer influences. These things kind of lead towards the potential risky behavior in the different situations that these children get into, whether it be drug abuse and alcohol, bullying and violence, sexually transmitted infections, homelessness, and mental health issues. I will go over all of these pretty briefly. Each one of them could be a talk in and of themselves. First is substance abuse. So there was an article, actually, 2017, Pediatrics, called Tobacco Use Among Lesbian, Gay, and Bisexual Adolescents. It was a pretty good study. They actually polled about almost 15,000. 88% were straight, 2% gay, lesbian, 6% bisexual, and 3.2% unsure. Pretty good stats there. What I wanted to focus on was down here at the bottom, which was the prevalence of current substance abuse. If you look at the first or the second column, the heterosexual straight, 20.7 said yes, as opposed to the gay lesbian, 33.1, bisexual, 31.7, and that is statistically significant. Drinking, 32.1 for heterosexual straight, 35.9 for gay lesbian, and then 41.8 for bisexual, and that was also statistically significant. Binge drinking, not statistically significant. Kind of going along with that, this is some other statistics from preventing substance abuse among LGBT teens. They said that sexual minorities are 1.3 times the odds of heavy alcohol use, 1.6 odds of marijuana use, 2.9 of injection drugs, and 3.3 of cocaine use. So, and what they noticed from that study was that being lesbian actually affected girls' substance abuse risk more than boys, even though boys were still prone to use overall. Kind of looking at the more studied substance that's being abused is tobacco. In general, the risk factors are family history, mental health behavioral disorders such as depression, anxiety, ADHD, trauma, whether it be physical or sexual, or have witnessed these traumas, and then impulse control problems. I think the mental health and the trauma is where we kind of have the cards stacked against our LGBT youth in regards to this. So that same study from the tobacco use among lesbian, gay, and bisexual adolescents, I kind of just want to focus up here on the any tobacco use. If you notice, for the heterosexual females, about 25% said they had, and then for the gay and lesbian, it was about 41%, and then for the bisexual, about 40%. It's a huge jump. And for the males, for the straight, it was 33.6. For the gay and lesbian, 38.8. And then for the bisexuals, 35.6. So what this shows is that lesbian bisexual girls have a higher prevalence of reporting current use of tobacco products, whether it be cigarettes, cigars, or e-cigarettes. The only thing they didn't go higher in was smokeless tobacco. Sexual minority boys had very similar smoking behaviors compared to heterosexual boys, so they're just making bad decisions all around. Heterosexual and straight or unsure adolescent boys had a higher prevalence of using tobacco, just kind of like the previous study with the other substance abuse. I had no idea that the lesbian and bisexual females were at a higher risk for smoking at all. So that's somewhere area we can focus our screening on. Moving on to experience with violence, whether it be physical or bullying or verbal, from the National Youth Risk Survey, it says that 10% were threatened or injured on school grounds, 34% were bullied on school property, 28% were bullied electronically, 23% who had dated within that past year had experienced dating violence, 18% had physical dating violence, and 18% were forced to have sexual intercourse at some point in their lives. In regards to dating, this is kind of my own personal take on it. Dating's hard at baseline, but whenever you don't exactly know who you are, you're already part of a very small group. And then the person that you like, you're not sure if they actually like boys or what. Sometimes when you find that person, you kind of latch on to them and you kind of put yourself in bad experiences more often. And then there's also kind of, when you have two males together or two females together, they're more likely to come to blows than whenever you have like a female and a male. In regards to school, from the Human Rights Campaign, it says that they 2 times more likely to say that they have been verbally harassed or called names, have been physically assaulted, have been excluded by peers. Kind of interesting, from this survey, they also kind of broke it down into where they were hearing positive and negative messages from. And so that's what this next slide shows. It said, they polled them and said, where are you hearing your good messages from? Where are you hearing, confirmation? 88% said the internet, 69% said from their peers, 59% said from movies, 41% said from schools, 32% said from their families, 16% from elected leaders, and 8% from community leaders, 4% from religious leaders. So these is where they're hearing their positive messages from. The negative messages, 74% said from school, 69% said from peers, 70% said from the internet, 68 from religious leaders, 60 from elected leaders, 46 from family, and so on. If you kind of put this into perspective, yes, they're getting a lot of wonderful resources from the internet, but they're also getting a lot of negative from there as well. And what kind of shocked me a little bit was the community and religious leaders. I think I've kind of just learned to kind of tune all of that out. But they're more prone to get these negative messages from the people that we're supposed to be looking up from, the people that are running our country and our religions, is where we're getting a lot of negative messages. Moving forward, sexually transmitted diseases. As a group, sexually transmitted diseases have been on the rise for this community. Screening is not often performed regularly or inappropriately due to delayed seek of care or lack of communication. Lucky for us, the CDC has literally all of the guidelines for you. I'll kind of talk about why MSM, which is youth males who sleep with males, why WSM, young youth women who sleep with women. I won't really go into transsexual or transgender because we've already had a grand rounds on that. So for men who sleep with men, HIV at least once a year. Syphilis and hepatitis B for those at risk, or high risk behavior, which is going to be your YMSMs. And hepatitis C if you're born between 1945 and 1965 and have high risk behaviors. This is the part where I think that we're missing, because I personally have never done one of these. Chlamydia and gonorrhea of the rectum if you have received anal sex or are bottom once a year. I've never done that on a patient. Chlamydia or gonorrhea of the penis if you've had insertive anal sex or are top or have received oral sex within the past year. We do that when we do the urine. And then gonorrhea of the throat if you've given oral sex in the past year. I've also never done that, but kind of the statistics that I didn't quite know, which is, kind of scary. In 2015, the age group 13 to 24 accounted for 22% of all new HIV diagnoses in the United States. 81% of those were gay or bisexual men. This age group are least likely of all age groups to actually seek health care and have a suppressed viral load. The kind of graphic down there at the bottom says that 68% will have care within the first month, 55% will retain that care, and only 44% will have a suppressed viral load. Breaking it down a little bit further, African American, Black communities, and then Hispanic and Latino males, that's where you're going to see the highest rate. That's where we need to be screening everyone, but we also need to make sure they're paying particular close attention to these groups. My own kind of personal take on HIV, I have several friends who are HIV positive. A little bit of a story. So, came out at 22. Someone was dumb enough to start dating me. Went on for about a year, and then I started medical school, and we all become awful people when you're in medical school. So that obviously ended. Remained really good friends, still one of my best friends. I got a text message one day, years after, and it said, check on him. I was like, okay, that's weird. So I called and I was like, what's going on? And all I could say is, I can't say it, and he hung up the phone. I got a text message not long after, and it was, I can't bring myself to say the words. I was like, well, what's going on? And all I could say is, I'm positive. The entire lung, the breath went out of my lungs. Even being in the medical field, my first thought was, life's over. It's done. But watching him do well and take his medication, live a normal life, has been one of the most eye-opening experiences for me. As a society, I think we still view this as being, it's not a good thing, obviously, but it's not a death sentence, and these people live happy, normal lives. They just take some extra medication. And then screening for YWSM. From the CDC, it said there's few data available on the risk of STDs conferred by sex between women, but transmission risk probably varies by specific STDs and sexual practices, be it oral genital sex, vaginal anal sex using fingers, hands, penetrative sex items, and oral anal sex. So we basically treat these girls as if they are sexually active teenagers. We screen for chlamydia and gonorrhea. Moving on to homelessness, which is also something that I had no idea. So from the Human Rights Campaign, it says an estimated 40% of homeless youth identify as LGBTQ. These young people cite running away from home or being rejected from their families because of their status as the two most common reasons for being homeless or at risk for being homeless. This puts our LGBTQ youth at 120% more likely to experience homelessness from our straight or heterosexual individuals. And this is rooted in lack of acceptance, both inside and out of their homes. Mental health, there was a lot on mental health. I kind of just broke it down a little bit, just kind of the bare bones. This is from the Mental Health and LGBTQ Youth. It says, on the one hand, there have been dramatic social changes regarding the societal acceptance of LGBT people and issues. And yet, on the other hand, there has been unprecedented concerns regarding LGBTQ youth mental health. So there's just a global increase in mental health problems. And the statistic that stood out to me the most is that 20% of sexual minorities reported attempting suicide compared to our 6% of heterosexual individuals. This is where our heads exams become crucial. I know a lot of times we will, sometimes we do those heads exams and we're kind of cringing, not sure what they're going to say, because sometimes those questions can lead to other questions and lead down a whole other avenue, but we have to do them. It could save a life. What can we do? How do we improve communication? So on to the third objective. Create a welcoming environment is the big thing. Many teens will go in, many teens avoid going to the doctor for the same reason that I did, because of real or perceived homophobia, biphobia, or transphobia. Patients will often look for clues. They'll look around the waiting room to kind of determine how comfortable am I sharing this part of me. There's also things that you can do. You can participate in referral programs through places like the Gay and Lesbian Medical Association. Actually, you can fill out you can type in that you are an LGBT-friendly physician. What are the clues that you can use? You can do brochures and other educational materials. You can display LGBT-friendly symbols and stickers. I actually hate the rainbow so much, but I appreciate what it stands for. You can exhibit posters showing racially and ethnically same-sex couples. You can display a non-discrimination statement, for all of your patients to see. And you can actually acknowledge relevant days that mean something to this community, whether it be World AIDS Day or local LGBT Pride. Do not walk into the room and do what we are all guilty of doing and saying, "So, you got a girlfriend?" Never assume at all what your patient, how your patient labels themselves or who your patient is in a relationship with. Consider using intake forms. This may help the uncomfortableness of the physician and the uncomfortableness of the patient as well. Don't use terms like boyfriend, girlfriend. Use partner or significant other. Use your patient's language, and when you're confused, ask for clarification. Some kind of caveats. Be aware that just because someone labels themselves as a bisexual doesn't mean they can't be in a long-term relationship with someone of the opposite gender. Also, whenever I say use the patient's language, be aware that they may use terms like fag or dyke. Those are terms that a lot of times the community is trying to reclaim those words, take the power away from them being negative. It's not there yet. It's not time for us to use them. Don't label your patients. Let them label themselves. Or not label themselves, whichever. And so some examples of some intake questions. Ask what your preferred pronouns are. Are they he, him, she, her, they, them, other? Other is perfect on these intake forms. What gender do you identify as? Male, female, other? What is your sexual orientation? That whole list that we talked about in the beginning. Straight, gay, bisexual, queer. And then what's your sexual, I already did that one. And then the last two are kind of more for almost parental intake forms. What is your relationship status? Having married on there, separated or divorced, it kind of leaves off that partner section, which has kind of been my code word. In all honesty, partnered is what I use. I've had to use it a lot more because I've been searching for a job. And it always gets kind of uncomfortable whenever they ask if I'll be moving alone or if I'm married. And I'm like, how's this going to go? So I say partnered, and that's my way of saying it to where they all know what I'm talking about. And there's always a pause, and then we keep going. And then children in the home have options like living with my spouse's or my partner's children. Some other intake questions. What safer sex methods do you use, if any? Do you need any information on any safe sex techniques? If yes, with who? Boys, girls, other? Do you have any concerns with your gender identification or expression or your sex assigned? And do you currently use any types of hormone, testosterone or estrogen? A lot of the trans community will, if they're not able to get the hormones that they need, they will find other ways to get them, and they're not always the safest. Confidentiality, we need to let our patients know that they're protected. We need to let them know that we are there to support them. So consider developing and distributing a written confidentiality statement. Discuss the degree of the patient being out. You need to know how comfortable they are with people knowing that they are part of this community. You've got to be aware that they're vulnerable to the social stress, and you also have to let them know what we can't keep confidential. You can't let them open up and at the end be like, ooh, gotta tell your mama. That's not how that's gonna work, and it's not gonna go over very well. Staff training, we need to make sure all of our staff is trained. When possible, hire someone part of the community. Train all frontline staff in the office to respect towards the community. Circulate guidelines to all staff and periodically train so we can keep up on our terms. And develop a list of resources. What is it that we need to talk about with our staff is to use appropriate language when addressing. If someone asks you to refer to them as him or her, refer to them as him or her. Be respectful. Learn how to identify and challenge your own internalized beliefs. You're here to take care of these kids and the family. You're not here to push your beliefs or discriminate. Basic familiarity with LGBT health issues, and then know how to refer out to LGBT-friendly providers if need be. Nearing the end, I actually made this talk and then completely did not think about an entire portion of it. I kept saying LGBTQ medicine and pediatrics, and I never thought about the parents. It wasn't until I was talking with Dr. Chapa about it, and he was like, come on, get it together. So just because we say LGBTQ doesn't mean I'm just talking about the patient. I'm talking about the family as well. I don't know about you guys, but I have quite a bit of lesbian moms that come in with their kids. So from the American Civil Liberties Union, this quote says, all of the research to date has reached the same unequivocal conclusion about gay parenting. The children of lesbian and gay parents grow up as successful as children of heterosexual parents. In fact, not a single study has shown that children of lesbian or gay parents to be disadvantaged because of their parents' sexual orientation. So there's no evidence to suggest that being lesbian or gay are unfit to be parents. Home environments of gay and lesbian parents are just as likely to support a child's development as a heterosexual parent. And then good parenting does not come from your orientation. It comes from your ability to create a nurturing and loving environment for that child. Your child is not going to be less intelligent. The child is not going to suffer from more problems or be less popular or have a lower self-esteem. Will grow up happy, well-adjusted, just like heterosexual parents' children do. And so I'm coming to a close, not too early. There's one last video. I did this talk because I'm hoping that we can foster an environment and have clinics where these children feel seen and they know their own worth. If we can have a child that walks out of the clinic and feels as if, they're not different, I think we've done something. There's just one last video.
Get on third base over here. Come on, gentlemen, let's move it, move it. Don't put your hand inside the glove, let the glove do the work.
Hey, Dylan. Good to see you again. How are your parents?
They're doing well, ma'am.
So far, with 2 outs, Williams with a 3-2 count. Friends into his windup. Here's the payoff pitch to Williams. He swings, he misses, strike 3. So,
Nolan? Can you come down here?
that's it.
Damian, thank you. That was not only an excellent grand round, but the way you framed it and your personal experience. Thank you. That was great. Go up here and then here.
Yeah, first of all, that was awesome, and I really, that's our time. But I appreciate the fact that you shared your experience, because I think unless you know people that have gone through this and hear their stories, you don't really understand the pain. So it was very brave of you, and I really appreciate that. Second, I'm wondering if there are resources for parents, because if you think of by the time we get these kids as adolescents, so much of the trauma has already occurred. But you yourself said, and many people that I know, they'll tell me, my 5-year-old grandson, I'm sure he's gay. He's just showing some of those behaviors. And you never really know, what to tell them at that point. But I'm just wondering if there's resources that would help with accepting and understanding when they're younger, so they're not going through all that pain.
A lot of CDC and AAP, they both have a parent section where there's just a list of resources. And then for our older kids, the Trevor Project, I looked that up for the first time, and you can live chat, and you can phone call 24/7 with someone to kind of help you go through these things. So there are a lot of resources. You just gotta know where to look for them.
Go ahead.
Yes, on the same line, I have some patients that have opened up to me for the first time without their parents knowing. And at that time, I feel like I'm at a loss whenever they ask for resources here in the community. Who can they talk to? Who can they go about aside from me about trying to tell their parents?
Unfortunately, I don't know of a lot in the community besides there is a Philadelphia Center, but that's kind of older than what our population has. I honestly think that the Trevor Project on the online, if you just look it up, you can just click on it and you can open up a text box just to talk to someone. That's a safe place to talk to someone as opposed to getting on random chat rooms, and that's not always the safest place to do it.
Pace here in town has a new group, so adolescents, you've heard of them.
Every time I've seen things it's always kind of small. I'm not sure. Yeah. Okay.
Comments? Yeah.
You have a patient come in, same-sex parents. Do you have any suggestions on sort of a sensitive way to ask about sort of biological status, foster versus adoption versus?
That usually comes up whenever I ask family history. If I'm asking, I need to get an idea of, what this child is at risk for, and I'll sometimes ask, who's a biological mom? And that's not an inappropriate thing to ask. And most of the time, we'll go ahead and tell you anyway.
So it's very clear from what you said, Damian, that very often as a young person is sort of trying to come to terms with what they're feeling, that a physician might be the first adult that they can talk to and help understand what's going on. And so I think it's really important that you take to heart what Damian presented, because I think you can be an incredible help to an individual by being supportive, by understanding, by respecting and paying attention. So I think it is an incredibly important part of what you do as a provider. So I think it's very important, so thank you. Great. All right, other questions or comments? Okay, thank you.